Raghuram Bhatt sir, and our today's speaker, Muralidhar Sharma sir, and all the participants joined today's webinar. We are here with the 8th episode of a webinar series, which is aimed to express the contribution of Sushruta to general surgery in general, that made Sushrutacharya the great, who is considered as the father of surgery by modern era too. The name of the series is The Vociferous Echoes of Sushrut Samhita. We'll start the program by Dhanvantari Namana. Before that, today we have with us Dr. Raghuram Bhatt sir, who is the President NCISM, and Dr. Muralidhar Sharma sir, who is a senior professor from the Shalyatantra, is a renowned practitioner, Ayurvedic practitioner from Karnataka. So we will know about them, both of them, by our moderator, today's moderator. We'll start the program. Today's topic, as everybody know, that the Sushrutas, the legacy of Sushruta's outlook on surgery wing of medical science. I request Dr. Snehal, who is our postgraduate from Department of Shalyatantra, to recite Dhanvantari Namana, and by which we start the program. Dr. Snehal.
Okay, sir. Thank you, sir. Om Namami Dhanvantari Adidevam Shurashure Vandita Pada Padmam Loker Jararupaya Mrityunasham Dhatarmesham Vividoshadinam Kshirabde Ruditam Devam Pitavarnam Chaturbhujam Namami Dhanvantari Nityam Nanagadanishurdanam.
Thank you, Snehal. Now I request Dr. Anuraj, who is also a postgraduate from the Department of Shalyatantra, Dr. Vyakar Government Ayurvedic College, who is today's moderator on behalf of Dr. Vidyaraman, who could not join because of some reasons. Dr. Anuraj, please proceed.
Yes, sir. Yes, sir. Am I audible, sir?
Yes, yes.
Okay. Thank you, sir, for giving me this opportunity to be the moderator for today's session. Once again, good evening, everyone, and a very warm welcome to all of you to today's session on the topic, the legacy of Sushruta on surgical wing of medical science, which is being conducted as a part of our ongoing webinar series, Vociferous Echoes of Sushruta Samhita. Myself, Dr. Anuraj Thomas, I'm a final year PG scholar from the Department of Shalyatantra in Dr. B.R.K.R. Government Ayurvedic College, Hyderabad. Today, we are fortunate to have two renowned personalities with us. Our esteemed chief guest, Dr. Raghuram Bhatt sir, and our distinguished speaker, Dr. Muralidhar Sharma sir, whose contributions in the field of Ayurveda are truly exceptional. And indeed, it's my privilege and honor to introduce and welcome our honorable dignitaries to today's webinar session. Without further ado, let me introduce our esteemed chief guest, Professor Dr. Raghuram Bhatt sir, who is one of the revered figure in the world of Ayurveda, who has dedicated his life to the practice, promotion, and research in Ayurveda. Dr. Raghuram Bhatt sir obtained their BAMS from Bharatiyar University, Coimbatore, in the year 1994. Sir completed their MD in Draviguna Vijnana from Gujarat Ayurveda University, Jamnagar, in the year 2004. Additionally, Sir did YIC Yoga Instructors course from Swami Vivekananda Yoga Anusandhana Sansthan, Bengaluru. Sir possesses an impressive linguistic prowess, being proficient in speaking, reading, and writing Sanskrit, English, Hindi, Kannada, Malayalam, Tamil, Gujarati, and Tulu. Sir worked as the director and principal at Sushruta Ayurveda Medical College, Bangalore for 3 years. Also worked as the principal in Coimbatore Ayurveda College for 3 years from March 2015 to April 2018. Sir was the former National Executive Committee member and Karnataka State Convener of Vishwa Ayurveda Parishad, and also served as the State Organizing Secretary of Bihar in Sanskrit Bharati as a voluntary full-time worker, and conducted more than 100 Samskrita Sambhashana Shibiram and Sanskrit teaching training programs in many parts of India. Dr. Raghurama Bhatta received numerous awards and honors in recognition of their outstanding contribution to the field of Ayurveda. These include Acharya Award by Sairam Group of Institutions, Chennai, and was also appointed as guide and mentor for the project Ayurveda Samskritam, promoted by Sanskrit Promotion Foundation, New Delhi, sponsored by ONGC, India. Sir, we are deeply honored to have you with us as our chief guest today, and with due respect, I welcome you, sir, to address this session. Sir, please.
सर्वेभ्यः मम नमस्काराः। चतुर्मुखसमारम्भां सुश्रुताचार्यमध्यमाम् अस्मदाचार्यपर्यन्तां वन्दे गुरुपरम्पराम्। अहं हि धन्वन्तरिरादिदेवो जरारुजामृत्युहरो मराणां शल्याङ्गमङ्गैरपरैरुपेतं प्राप्तोऽस्मि गां भूय इहोपदेष्टुम्। This is how Dhanvantari has introduced himself to Ayurveda. Acharya Dhanvantari has brought Ayurveda to this earth as per the Dhanvantari school people. Mainly Shalya Tantra is the subject, and also along with Aparaihi Upetam, other Angas were also there, but mainly it was Shalya among the Ashtangas of Ayurveda, which was being propagated by Dhanvantari in this earth. Listening to the legacy of Sushruta, who is considered to be the first Acharya or first person to write a treatise and propagate Ayurveda in this country, by the legend of Shalya Tantra, Sri Muralidhar Sharma is really a feat to the ears of the listeners. I salute our Guru and great practitioner and great teacher, respected Vaidya Muralidhar Sharma in this occasion. Also the A. Sridhar sir who is arranging this, and also I salute the listeners, various Ayurveda Vaidyas from various parts of country, especially Andhra Pradesh and Telangana here, who are representing Vishwa Ayurveda Parishad as well in this occasion. Shalya Tantra is a special subject which has become extinct due to the atrocities of the invaders, as well as due to the following of Buddhism, the Ahimsa. Unfortunately, the practice of Shalya Tantra was lost in India. When the English people came, the surgery was developed by them. Even the modern surgery or modern surgeons believe that Sushruta is the first surgeon of this country, of the world, and he is believed to be the father of surgery, and all the surgical instruments which are there even now are derived from the surgical instruments which are being prepared by Sushruta and his followers. So it's our utmost and foremost duty to develop this surgical science in Ayurveda as well and establish the last glory of surgery. In this divine or important work, various Shalyatantra people or Shalyatantra Visharadas, surgeons of Ayurveda, are putting their effort, dedicating their life. One among them is Sri Muralidhar Sharmaji, who is here to deliver the lecture, and others like starting from Manoranjan Sahu or Kulwan Singh Ji or other specialists of Shalyatantra. Always their effort is to be remembered always, because now the Shalyatantra is being established in this country, especially in the field of Sharasutra, Raktamokshana or Agnikarma and so on. And a major point which is to be told here is the Gazette, which is being published last 2 years back by Board of Governors CCIM regarding the right of Ayurveda practitioners, especially the Shalyatantra postgraduates with MS in Shalyatantra and Shalakya Tantra, to practice 56 surgical procedures, was a revolution in the practice of surgery in Ayurveda. I hope all the Shalyatantra practitioners will adopt the practice of these 56 procedures and develop these 56 procedures and propagate all over the world, and each and every institution will have the facilities required for this and teach the special skills of these 56 procedures, including the BRKR Government Ayurvedic College, Telangana. I thank the organizers for giving me an opportunity to inaugurate the function, and also to listen to the legend Dr. Muralidhar Sharma, and also being with you for this occasion. And I hope the lecture here will be very much useful for the listeners as well as the Ayurveda Vaidyas. Thank you, one and all. Namaskar.
Thank you so much, sir. Sir, for enlightening us with your inspiring words. Sir, your motivational words have really set the tone for this webinar. And we are immensely grateful for your support to us, sir. And it really means a lot to us. On behalf of all of us, sir, from the bottom of my heart, let me express our sincere gratitude for gracious participation and sharing your valuable insights. Once again, thank you, sir. Now, we all are looking forward for the lecture on the topic, the legacy of Sushruta's wing of medical science. Today's our distinguished speaker, Dr. Muralidhar Sharma, sir, is a highly respected expert in the field of Shalyatantra and is known for their extensive research and innovative approach in this field. Professor Dr. Muralidhar Sharma, sir, obtained their MD in Shalyatantra from the prestigious Banaras Hindu University, Varanasi. Sir started their academic career in 1983 as lecturer in SDM College of Ayurveda and was the medical superintendent of hospitals from 2014 onwards. retired from the service in 2018 and serving as Professor Emeritus since 2018. Under Sir's leadership, the institution gained a remarkable growth of the Shalyatantra department from the scratch. Currently, the department has got recognition of being a center of excellence in Shalyatantra training and practice. Under Sir's guidance, they developed an Ayurvedic protocol of Ayurvedic post-operative management and inclusion of technologies like endoscopes are the highlights. During their career, Sir also served as the resource person for many workshops, conferences, and CMEs across the country. In terms of Dr. Muralidhara Sharma Sir's publication profile, Sir authored more than 15 publications. Furthermore, Sir received numerous awards and honors, which include National Sushruta Award and Best Teacher Award by RGUHS and National Sushruta Association. It's a great privilege to have Dr. Muralidhara Sharma Sir as our speaker today. Sir, with all due respect, let me welcome you, sir, to enlighten us with your extensive knowledge and wisdom. Sir, please.
Okay, thank you. So, I hope I can share my video, the screen as
Yes, sir. Sir, I made you co-host. You can share your screens.
Okay, is the screen visible? Whether the screen is visible to all or not?
Not yet, sir.
Already, so the,
Yeah, it's coming now. Yes, sir. The screen is visible.
okay, all right. Thank you, Dr. Sridhar and Dr. Raghuram Bhatt, who is a close friend of mine also. And let me start with the topic directly. Of course, the basic issue is Ayurvedic principles in the contemporary surgery. Now, Dr. Raghuram Bhatt referred to Sushruta as father of surgery with due apologies. I would say, I would not name Sushruta as a father of surgery. Because if you consider father, then the next question comes in, who is the mother? And without mother, you can't have the child also. So, rather, Sushruta, I credit Sushruta for having a documented evidence of the surgery and streamlining the education of surgery, methodical education of surgery, and establishing the principles of surgery as the first documented evidences. Surgery was there the moment the human being was born, or before the world was created. The surgical principles were created. Every human being who has an umbilical cord or who was born with an umbilical cord has undergone a surgical treatment at the time of the birth, and hence even before Sushruta the surgical techniques were there. But credit to Sushruta would be bringing that level to a level where the whole universe would be now still considering, still having that values. Even after 5,000 years, the values are there. It's not only about doing surgery, it's about how to live as a surgical principle. And the whole concepts of education of the surgery and streamlining the training and all the other positive values of the surgery are established and documented. That's the specialty. Now coming to Ayurvedic surgery as such, the Ayurvedic surgery has a speciality, and that speciality is, see, Ayurveda is the science where the surgery is considered Shalyatantra, or Shalyatantra is not surgery alone, there are other aspects too, but let us consider Shalyatantra, the main scheme of the Shalyatantra is about surgery, where the Shalyatantra is considered as Ashtasami Ayurveda Tantreshu Etadeva Adhipam Abhimatam. It is the most common issue. At the same time, a surgeon would have to have a training in all the other branches. Then only the surgeon would be capable of doing surgery, because the surgery is a field which requires maximum skill, as well as it has a synthesizing approach with the other discipline. That's why it's called as a Sarvatantra Samanya. At the same time, speciality of Sushruta is with the same voice as Shalyatantra is considered as Adhikam Abhimatam. in the next sentence, there would be, may not be in the next sentence in the same chapter, but in the same book, there is a specific description where Upakrama Jaganyoyam Atha Samparikespraha, that Upakrama surgical treatment is considered to be one of the risky profession, and Kushalasyapi Vidyasya Siddhi Iha Adhuva. Even if an expert person may not have the perfection, or to get the perfection in the field of surgery is very difficult, and hence it is considered as a Jaghanya. Jaghanya word is something like inferior. Now, and one word it says that Isaiva Adhikam Abhimatam. In the next there is a narrative saying that it is Jaghanya. Now, this gives that broader view of approach to the science. You have both the plus and minus, and the advantages and disadvantages, and that importance of what not to do and how not to do as the basic ethics of surgery, or basic ethics of surgery, than really what to do and how to do. That would be the secondary. Now, that's all the value of the major value of Sushruta surgery. Moreover, the evolution of surgery in Ayurveda is a perfect blend of medical and surgical disciplines. If you go to Charaka Samhita would say the whole protocol of treatment of a disease is categorized as Antaparimarjanam, Bahiparimarjanam, Shastra Prandhanam Cheti. The whole basic concept of the treatment from Ayurvedic point of view is initially whatever the vitiated factors, which we call as doshas, it has to be removed or it has to be pacified by maybe the shaman aushadis, medicines. If not, it can be separated by a specific procedure of which you consider as shodhana, and which is now part of what we call as a panchakarma. When this also is not capable of removing the lesion or curing the patient, then comes the Shastra Prandhana, that vitiated component of the body. If it is localized and if it can be extracted out, it can be removed mechanically, a direct intervention. So the method, that intervention in the treatment, is a step-by-step evolution, starting with the Antaparimarjana, where some medicines are given, and with that the treatment is achieved. Or it could be like removing some of the vitiated components as such by a less intervening treatment, or where you may not directly handle the vitiated contents directly. Instead, you have a protocol of bringing that vitiated components to the Asana Marga, the nearby route, and then bring it out either in the form of Vamana or Devretana. Or still the higher level would be when the vitiated components directly handled and then removed. So that's the basic evolution. So that step-by-step evolution of the approach to the treatment is one of the scientific factors or very crucial speciality of Ayurvedic approach. At the same time, Sushruta has given the warning, like the surgical approach or a direct handling should be the last option. When all the other options are exhausted, then only the surgical option has to be done. Ratra shastrasadhyeshu snehadikriya na pratisiddhate, snehadikriya sadhyeshu shastrakarma na kriyate. Doing surgery or handling directly, intervening directly, is absolutely contraindicated whenever there is any other possibility. Only when all the other possibilities are exhausted, a direct intervention is done, because that direct intervention is a risky protocol, has many complications, and ultimately it directly affects the physiology. And hence it has to be considered as the last resort. And the protocol of doing the surgery was done by a stream of specialists who are called as Dhanvantariyanam Adhikaraha. So when Charaka also would accept the surgical stream as a part of the medicine, which is a specialized area, and those specialists who are now maybe recognized as surgeons, they are capable of doing such a protocol, and Charaka would reserve such protocols of Vedha, Shodhana, Ropana, and so on, all that direct interventions to Dhanvantariyana. Now, again, to establish what I am saying, I would again say Rakta Vistravana, where the vitiated component of the blood is directly removed without undergoing the protocols of the asana marga, snehana and svedana protocols. See, in the shodhana protocol, you have that protocol of making that dosha, the vitiated component, coming to the asana marga, and then only the dosha are removed. In the Rakta Visravana, it's about the removal of the vitiated blood directly from the area without that protocol of separating. So that Purakarma is not a essential feature, though Purakarma is mentioned as such. And that's the one area where the direct intervention is done, and Sushruta has mentioned specific disease conditions where this kind of a protocol would give the results. Then the next part, so if this also is not or may not be enough limitations, the next part is directly intervening the vitiated tissue which has become separated. So if you go into the Shatkriya Kala description, the protocol procedure of formation of the disease, you have that step-by-step involvement of the tissues, where ultimately you will come to a stage where the pathology becomes irreversible, the Bhedavastha, and once it reaches that stage, even that protocol of Shodhana, where the dosha can be separated, Utkrishta dosha cannot be removed, or even the Raktamoksha may not be enough. In such conditions, either the vitiated dosha has to be drained out if it is separated by the body. For draining out, the Bhedana, the Vedana Shastrakarma are done. If that vitiated dosha or vitiated component has been separated by the body, and it facilitates, your procedure is to facilitate that vitiated component directly, or if it is not liquefied, if it cannot be removed by a procedure of draining, then it has to be excised, removed. That's a Chedana and Lekhan. Now, this is the very methodical, very scientific approach of targeting the diseased components. Which sort of things are not seen in the contemporary science. In the contemporary science pathology, this kind of a procedure is not really used clinically. So, these principles are known, these principles are established pathologically, but the approaches are not so much specific, step-by-step approaches. Of course, the other surgical procedures, which we call as Ashtavidya Shastra, they are to facilitate these basic procedures, Ashana, where it helps in identification of that vitiated component, which is a diagnostic intervention. Aharana is a removal of a foreign body. If the lesion is not endogenous, if the lesion has been an external object, then it has to be removed mechanically, and for that the aharana. Sivan, of course, the ultimate, where the wound has to be closed. Now, this is about the method or how the surgery was there 5,000 years ago in India. Very evolved. Of course, I will not waste much time on that evolution. Every protocol, every aspect of the surgical treatment was considered, hygiene was known, and the post-operative recovery, post-operative complications were established in Samhitas. Compared to, again, my purpose is not to criticize the other system, but a bit of comparison to the Western issue. If you look into the history of surgery in the Western system, the surgical discipline was never a part of medicine till around 19th century, 1843. For the first time, the medicine was considered to be a part of the, or surgery was considered to be a part of the medicine discipline. And in 1840s, early 40s, the attempts were done to include the surgery into part of medicine. Till then, surgery was in the field of barbers, in the hands of the barbers, and they were not considered as doctors. They were considered as something of a different sort of thing, or rather, even the surgery was limited to or considered to be something, an esoteric act, where a person who is possessed, he would be that possessed body, Buddha or Buddha chest or something of that sort, would be chased, that possessed component would be chased out by the surgeon. And the earlier history, if you look into the history, a surgeon would be applauded when he has more blood stain in the body, or when the patient cries more, then the surgeon would be applauded. And the surgery was done as a dramatic issue. People used to observe the surgery or enjoy the surgery in a theatre. And even now, the same nomenclature, like surgical theatre is still continuing. Of course, surgery is not a job of theatre, it's not a dramatics. It's rather we should be doing in a operating room which has a very sanctity. So naming that operation theatre even now is a misnomenclature, but it has come from the tradition of thousands of years back. And interestingly, I am just quoting one sentence, established sentence, when there was a discussion in the UK Parliament about including the surgery in the medicine. One of the parliamentarians, Lord Tubergo, he commented, there is no more science in surgery than butchery. This is one of the statements. This shows, I am just putting out one sentence from the history just to show the status of surgery at that period. Even now, Royal College of Surgeons, the products of Royal College of Surgeons would not put their name as doctor. They would not put the suffix of that doctor in front of their name. Instead, the title still remains as Mr. And there is a movement to change that. That's the current issue as such. Now, comparing this history or the situation of surgery in the past in West and compared to what Sushruta had done and what was there in India, there is a huge gap. But unfortunately, even or maybe the other way, I would not use the word unfortunately, I may not be justified. But what has happened in the West is, in the whole history of surgery, which is just around maybe 200 to 300 years. So actually, surgery was included as a part of medical stream in 1843, where the Barber Surgeons Guild was changed as Royal College of Surgeons. And from there onwards, the development of surgical discipline is so vast, so huge, and technology has overtaken anything, right? And it's the whole idea of our concept of ayurvedic surgery has been put into the background, and it looks like the whole branch has become extinct. This is the situation, and of course, the responsibility of this is on all, including all of us who are the followers of Ayurveda even. So my purpose is not to go into that part, but at the same time, it has to be observed like that whole rapid development which has occurred in the Western surgery is a model which we have to see and appreciate at the same time. Though the history, in the historical fact, Ayurvedic surgery was at a very superior level, but in the present day situation, without any difference of opinion, the contemporary surgery has overtaken a lot. Now anyway, that's about the history part. Now let me directly come into the topic of that legacy of Sushruta and the contemporary surgery as such. So primary question is, what is surgery? Some people may feel that surgery is an act of cutting and suturing. So if it is a cutting and suturing act, a butcher and a tailor combined together would be a better surgeon. But it's not. That's not the equation of surgery. The surgeon's equation or surgeon's position is totally different. Whatever the act of cutting and suturing is just a very small, minuscule component of the total activity a surgeon would do. A surgeon would be actually living on or based upon the three tripods, and the three tripods on which the surgery is established or maintained, or maybe developed in the contemporary science also, are based upon the concepts, principles and ethics, and then the technology. Now, which of the support of the tripod is more strong? Of course, it's a matter of debate. Some people say that technology is the strongest part of the tripod. Some would say concepts and principles are the most important. I am of the opinion that concepts and the principles are the more important part of the tripod, supporting tripod, than really the technology. Of course, it's a matter of debate, so I will not go into that part of the debate. Now, whether Sushruta has established those principles or not. So I will be now trying to look at Sushruta about these concepts, principles and the technology, and trying to compare the same as we see it now. Now, again, to go into all the details in 1 hour's duration is practically not possible. So I will be just limiting to a few of the examples of establishing what Sushruta had presented as the basic concepts of surgery, and how the same concepts of surgery are translated in the contemporary science to a certain extent. Now coming to those basic, certain of those basic issues, the first of the thing I would refer to would be the concepts of chedana or excision, where a tissue is removed. A vitiated tissue has to be removed. The indications for chedana mentioned by Sushruta is apakeshu turogeshu kathineshu sthireshu cha snayukothadishu tada chedanam praptamuchyate. When the disease is irreversible and is presented as a firm swelling, localized swelling, something like the tumor pathology, or a irreversible disease again like the tissue death, gangrenous conditions, in that condition chedana is considered. So primary concept of removal of a tissue component of the body as a treatment is when the pathology is irreversible. If the pathology can be reversed by any other means like the snehana, svedana or any other shodhana chikitsa etc., then that has to be treated with the other protocol. Only when the lesion has come to that stage where it has become irreversible, then it has to be removed. If you look at the contemporary surgery, there again the basic idea of removing an organ or removing a part of the body is exactly the same, only in the irreversible pathologies as such. But there is some extension. The extension is mainly if the organ is dispensable, or at times the surgical removal of an organ also is done as a prophylaxis to prevent the disease. These are the two additional issues. Dispensability of an organ is if the organ after removal, if it doesn't affect or if it doesn't produce a significant pathology, observable pathology, then that organ can be removed. Something like a harmless organ or a organ which is not very conspicuous, a silent organ, is easily removed, like appendix. See, appendicitis is an inflammatory pathology and it is not irreversible. But still, the first approach to the treatment is removal of the appendix, excision, appendicectomy, because it is dispensable. By removing it, it doesn't affect the area. Now, that's the idea. And hence, majority of the surgeries which are done are based upon that dispensable organs. Now, whether an organ is absolutely dispensable or not, whether the harmful effects are produced or not after a removal of this organ is still debated. See, one basic principle is in the creation there is no wastage. Creator has established or given you everything because with a specific purpose, and there is no wastage as such. But we do not know the exact utility of that. Because the functions of the appendix are not known, and you remove the appendix, you do not know what has happened to the body, and we say that appendix is a dispensable organ. But the same may not be true with the heart. Heart is not removed so easily. Of course, if at all you have to remove, you have to go for the transplantation the other way. Technology has gone to that level, but it cannot be removed. That's what I mean by dispensability. Then the other is prophylactic. See, suppose the whole basic of the prophylaxis is again, if you look at the history of evolution of different procedures, like till 1882, the standard protocol of the treatment for gallstones was cholecystostomy. Gallbladder would not be removed. At that time, people considered gallbladder as an indispensable organ, and removal of the gallbladder would produce more complications, and cholecystostomy was the standard practice. History, if you look at the history of cholecystectomy, that removal of the gallbladder as a protocol, very interesting issue. One of the surgeons in USA, that's Karl Langbach, German surgeon, he accidentally removed a gallbladder without being aware of it when he attempted for the cholecystostomy, opening of the gallbladder to remove the stone. And at that time, the belief was that the removal of the gallbladder would result in a fatal complication. But interestingly, the patient survived without much of the complication. That surgeon was really afraid of reporting this issue to others because it was considered to be a grave error. But he had a curiosity. So in the next surgery, he intentionally removed the gallbladder and found that the patient had survived and the later complications were not significant. Now he started with a series of such cholecystectomies, and then it became a practice. And now in the present day situation, cholecystostomy is never done, and the cholecystectomy is the standard protocol, and the number of cholecystectomy, removal of the gallbladder, is increasing every year. And in India, the procedures in India, more than 3,29,339 cholecystectomy gallbladders were removed in 2022 in India, as per the data. The source of the data is there, and that's the issue. Removal of the gallbladder still is not harmless. There will be many post-removal, post-cholecystectomy syndromes which are there, but still it is considered as dispensable. So that is the hollowness of the theory of dispensability, which Sushruta or Ayurvedic surgery would not consider as the issue. Then comes to prophylaxis. Prophylactic therapy is removal is because an organ has a risk of developing a complication. You remove the organ before the complication has occurred, so that the complication doesn't occur. It is something like because there is a possibility of appendicitis, you remove the appendix. History says, like in German Marines, between 1890 to 1902, these are all the established facts in the history. To join the military, it was considered that appendicectomy has to be done as a protocol to prevent the possibility of a medical leave for a military person later on, to keep appendicectomy was recognized, or appendicectomy was recommended as a precursor or a essential procedure. And what observed is the patients, military people didn't develop appendicitis in the due course of time, but the absence due to the medical leave was more because of the other reasons. And they found that the whole issue is not really reaching the target, and that order was withdrawn in 1905. So the basic hollowness of that theory of prophylaxis is another of the issue. And of course, another of the example of the prophylaxis is removal of the uterus after the age of 50, once the menopause is achieved, considering that that organ now is useless, and in Western countries, almost more than 50% of the population has lost their uterus as such, even before they have developed any complications. Now the idea is you remove the uterus because it has a risk of malignancy later on. Now in India also this epidemic has started. So again we know it's already presented as epidemic of hysterectomy in India. So another cause of concern, another issue of debatable issue. Now this idea of removal or that organ, removal of an organ to prevent the formation of a disease as a prophylaxis also has its limitation. So you may remove a uterus, you may remove a gallbladder. Now because you want to prevent the gallstones, or you want to remove the uterus to prevent the uterine malignancies, I would say to prevent headache, why don't you remove the head? But that is illogical. That idea is primarily illogical. There is a limit to all that what is done. And now one of the most debated issue in the contemporary surgery is about the limitations of that kind of approach. But still, if you look at the total number of surgeries being done now, a larger share is from the prophylactic aspect, which is not Sushruda's cake. Sushruda would not accept these issues as such. Now coming to the basic other issues which are in Sushruda's period and which have evolved and modified. Now Sushruda has used not only the scalpel or the blade to remove the tissues, he has used the physical energy like Agni Karma or Kshara Karma, chemical energy, to remove the tissues. In the present day situation, technology has gone beyond that and used the other modified physical energies like electrical, ultrasonic, organ beam, laser and so on, which are considered as the superior technologies, but primarily making use of a physical energy as an alternative to the scalpel is originally an idea of Sushruta, but technology has now given you some more rich, more safer, more controllable tools to make use of them. So that's not against the principle of Ayurvedic surgery, but the idea of making use of the natural energy to remove the tissue is originally from Susha, which has evolved and which has developed, has many additions now. The other way is the chemical dissection. Instead of only the chemical dissection, making use of the kshara as a chemical to debride the tissue. Even now, you have many of such chemicals which could be used. Then, even in the surgical removal, so those who have practiced surgery may be able to make out that idea. The idea of removing the lesion completely, particularly in tumor pathologies, Arbuda-like conditions. If you do not remove the lesion completely, even or completely removing the sense, even a small border of the tissue, normal tissue has to be removed. So, sashesha doshani hi arbudani karoti tasya ashu punarbhavanti. Tasmat asheshani samudharet. That ashesha removal, samudharana, or a radical excision is again primarily a concept of Sushruta. If you do not do that, remove only the visible component, visible part of a lesion, it can result in recurrence, and that has led to the idea of a radical excision. The idea of radical excision came into the Western surgery. If you look at the history of Western surgery again, the Billroth in Germany and Halsted in Baltimore, their this presentation of cancer operations designed to remove the entire tumor is considered to be a breakthrough in the cancer surgery, and this came into practice in 1881, and in 1881 these three surgeons were given an award also, and now that value of a radical excision is established. Now you have many technological tools to confirm that the excision is radical, and that different approaches of radical excision are now being practiced. Now, it's not only the radical excision or a complete removal of the tumor. There is another option. If a radical excision is not possible, it's not salvageable, that removal of a radical a mass completely would harm the sustenance of the patient, then you have the other option, which we call as the debulking resection, followed by adjuvant therapies. A part of the tissue is removed, and whatever is left over is managed with the other therapies, though it's not as efficient as a radical excision. Now, this is again another of the newer approach in the contemporary oncological surgery. But what Sushruta has mentioned, actually she has already has that kind of a description 5000 years ago. If a tumor cannot be removed, in that condition, you remove this part by part, and then whatever is left over can be later on either curated out with the Agni Karma, or it could be even managed with the medical treatment. To removal by part, one of the very intelligent techniques used by Sushruta is Nishpava Pinyaka Kulatta Kalkaihi Mansa Pragadihi Dadhimasti Yuktihi Repum Vitadhyas Kramayo Yatha Atra Murchanti Munchanti Atham Akshtascha Alpavashiste Krimi Bhakshiretu Likhetato Agni Mirujita Paschata. In a tumor which cannot be excised directly, you induce the maggot formation, and the maggots should remove a major part of the tumor. Whatever is left over then can be handled better. So, making it convenient to debulk. Now, that debulking resection is one of the somewhat recent approaches in the oncological surgery. Though the tools used are different, you have more advanced and more standardized tools of dealing with this. But the basic idea of that debulking resection also is one of the Sushruta's concept. Now, coming to the other issues, Chedana. I have just presented a few of the issues related to Chedana and the principles, which are actually seen in the contemporary surgery as an evolution, and some of the differences there. Now, Bhedana or the Vedana, where a liquefied component of this lesion is removed when there is a pus formation where it's directly separated, the issue is separated, fluid is separated, and it can be made out clinically by the fluctuation. Antapuyeshu, avatreshu, tathaiva utsangvatsapi, gatimatsu jarogeshu. Gatimatsu is where the fluctuation is seen. In such conditions, you may have to make an opening and drain out the fluid if the process of the fluid formation can be reversed completely. Or the drainage as a basic surgery is better tolerated by the patient. If the condition of the patient is able to tolerate that Vedana or the incision, where the injury to the tissue would be more. Now, if the pathology cannot be reversed, as in case of Jalodhara or other conditions where the pathology cannot be reversed, the fluid formation may be continuous, or if the patient's general condition doesn't permit the making an incision where the tissue injury will be more, you insert a needle and aspirate. Now, even now, the principles remain the same. Opting for an aspiration or paracentesis or opting for a open drainage is based upon the same principles. The two factors, like whether the pathology can be completely stopped or reversed, or whether the patient's fitness is sufficient to have the protocol. So there is absolutely no change in the approach to that principles or concepts of the Bhedana or the Vedana. So drainage and paracentesis, in the current situation, the indications remain the same. Drainage are generally for exudative collection, terminating lesion where the disease can be completely terminated, and where the complete drainage is to the target as such, and it's a mean therapeutic course as such. Whereas the paracentesis is done as in cases of the transudative pathology where the disease cannot be terminated completely. I hope you make out the difference between the exudate and transudate. Or paracentesis is also used as a diagnostic utility to collect a sample of the fluid and then confirm the nature of the pathology, or it can be used as a palliative measure, though not a complete treatment, or patient's general condition is not so good. Then comes the issue of probing, Ashana. For Ashana, Sushruta had used simple mechanical probes which are soft and flexible. Even now we do use the same probes there, but at the same time, at the present, you have some more of the tools which are much safer. The whole probing protocol, though you use a soft tube or a soft this probe which is malleable, still because it is a blind procedure, it can harm the tissue. So now ultrasonography, one of the tools where it can make out the difference in the resistance of the tissue. The basic concept of the probing is to make out the difference in the resistance given to the probe. Like if in a case of fistulous tract, the probe is followed on the path of least resistance. Whereas if you are observing for or searching for a foreign body like a bullet or maybe a bone piece, you are looking for an area of harder resistance. Now that resistance being felt at the tip of the finger with a probe is the basic concept of the probing, and you use a specific tool for that. And in the present day situation also we do use exactly the similar mechanical probes. In addition to them, and of course the material for the probe also now you may have celestine material, more flexible material which are less harmful, but basic concept would be the same. In addition to that, now the ultrasonography, it follows the same principle of measuring the resistance given to the ultrasound waves. It's not the probe, and the instrument still has been named as a probe only, as that component of the ultrasonography machine which receives that ultrasonography waves which are reflected by the harder tissues of the body. It's called as probe, and that concept still remains. Now the basic issue is the principle remains the same. Technology tools have enhanced the accuracy of the your test asset. Safety has been more, scope has been increased, but basically it is the same asset. Then comes the Lekhana, one of the other surgical procedure, which is curating or shave excision, which is used now. Also we do use the same when either a complete removal is not possible or complete removal is not required. Otherwise the indications are similar for excision and the Lekhana, curating. The indications are similar. Kathina, Sthula Vrittavasta, that kathina or hardness and localized swelling is the issue. If a complete removal either is not possible or it's not required, in that condition you take a small part of that by curating. Now of course the curating is still one of the standard protocol in many conditions. Very popular surgery called as dilatation curating, used in obstetric practice or gynecological practice for diagnosis as well as treatment, therapy. It's done, and majority of the diagnostic procedures you do still use the curates, different sorts of curates now. So virtually there is not much of a difference, except that a certain additional indications like diagnosis as such. Otherwise, it's almost same as such. Concept of aharana by sushruta is again very interesting issue. The aharana by sushruta is not simply extraction. We do translate the aharana as extraction in India, but or in English. But I think that's not a very perfect translation, because the technique of aharana is a technique where you will see a hooked instrument and go behind the object to be extracted, a foreign body, so that the complete removal is possible. So to remove a tooth also, Sushruta would use a Danta Shanku, a hooked instrument to remove. So idea of making it a hooked instrument and going behind that object and pulling out, which gives a safety, ensuring a complete removal of the lesion, is the basic idea of aharana. If you look at the advanced techniques, in the present days, advanced techniques like the Fogarty's technique for removal of the biliary stones, or the clot removal with the angiograms and so on, the removal in vascular surgery to remove the blood clot, you make use of the probes with a dilatable component, a catheter which has a dilatable portion. You go beyond the scar or clot to be removed, dilate the bulb, then pull out so that the whole clot can be removed. With the Fogarty's technique also the same. There is an inflatable balloon and you insert that beyond the stone, inflate the balloon and then pull out. That balloon will act as a hook and remove of this. This kind of a technique of removal is the basic idea of Sushruta, aharana, when he refers to aharana. And now this is considered as one of the safe surgical techniques of extraction, and you have different names like Fogarty's technique and so on. Then comes the Visravana, bloodletting. Bloodletting was considered as one of the superior tool for treatment as such, and the Sushruta would always make use of the different techniques. I will not go into the different tools as such. The different techniques like Stringa, Jaloka, Alabu, Sirabhyasa, the different tools of Raktamoshana. But in all that, one of the important precautions which would Sushruta suggest would be Raktam Sashesha Dosham Kuryadapi Vichakshanaha. न अतिनिश्रुतं कुर्यात् शेषं संशमनैः जयेत. Whenever you remove the rakta or raktamokshana, it's not that you remove it completely. The lesion is to be removed completely, cannot be removed completely and should not be removed completely also. So you will be removing only as a part of the component. You will be diluting the pathology. Whatever is left over, it has to be treated medically, and Sushruta has given that maximum limit of the removal of the blood as such, and it should not cross, and harm could be more. Now, if you look into the history of Western surgery also, in the Western surgery, that Visravana or bloodletting was considered as a major, most important protocol of the Western surgical treatment. Stelzius, who is considered to be the father of the Western medicine as such, he had established, or he has presented as a, like, the bloodletting would be the most important disease or management tool of management, and there would be no disease which cannot be managed with the bloodletting. The exact sentence, the translated sentence is to let the blood by incising a vein is no novelty. But what is novel is that there should be scarcely any malady in which the blood should not be let. So every disease can be managed with the bloodletting, and the bloodletting was very popular, very significant, but the only thing which was not there in the Western science compared to what Sushruta has said is, Sushruta has given the warning like the blood should not be removed completely, that the limit has to be followed, and the indications are very specific. Srabya Vyadhis, the indications are very specific, only in those conditions bloodletting has to be done. But in the Western, it was the other way. It was done as a treatment for every disease. A principled approach to the bloodletting in the Western surgery started with the Ambrose Paré in 1634, where the indications for the bloodletting were specified as reduce platitude or reduce the congestion, divert the pathology, or elude, that you remove the component as such, or alter the situation of the body, or prevent the disease as such. These are the indications mentioned by Ambrose Paré, the first somewhat methodical approach where the principles were established was in 1634. Till 1634, it was like every disease it can be treated. The bloodletting was very popular in Western medicine till very late stages, and the event which has put the bloodletting into the disrepute is important. I am just referring to that part. In the issue history, if you look at the history of Western medicine, Benjamin Rush is considered one of the major practitioners, a huge, very popular surgeon of that time or physician of that time. And the bloodletting, it was not in the area of surgery at that time, it was in the hands of the physicians, medicine stream. And even before the Royal College of Surgeons started, or surgery came into the field of medical stream, bloodletting was a component of the medicine alone, medicine as such. And every disease can be managed with this. And the history says one of the major events which has put the bloodletting into disrepute and the present status is George Washington, who was the president of USA, first president of USA. The history says developed a chest congestion on December 12, 1799, and the physicians bled 1.3 liters of blood, but the same, because he didn't have a relief, the bleeding was repeated on second day on the advice of panel of physician, and he died on 14th of April 1799. At the time, it was believed that he died because of the pulmonary pathology, pneumonia as such. But later on, people started thinking about it. Lots of these controversies came in, and lots of research activities also are done. And in Edinburgh Conference in 1905, declared that hypovolemia was the cause of the death, and the protocol of letting blood was reviewed rigorously, and from that day onwards, bloodletting as a tool for every disease has become obsolete in the Western medicine. In the Western medicine now, bloodletting is limited to very few conditions like polycythemia and so on, but the whole disrepute has come to the tool. Now, the message there is, my purpose of referring to this history is not to bore you, or is not something excessive. Like, the message is, when a tool is used irrationally, it can result in harm and disrepute. Best example is the bloodletting, which is a very useful tool and which is handled irrationally, led to a situation where the president of USA died, and the whole technique has been put in disrepute, and now the existence of the bloodletting as a part of the tool in the Western medicine is very limited. It's very limited. I don't say it has become totally obsolete, but very limited, like a few of the conditions bloodletting is done, otherwise bloodletting is not done as a therapy. But the other parts have developed. Now the message is, it's an important message for all practitioners. If you follow any protocol without that controls, and if you do not follow that discipline and the standardized protocols, if you cross the benchmarks, then there is a harm of bringing the technique to the disrepute. Whether this is really right or wrong, in the current Ayurvedic stream of surgeons, many times there is a risk, like I am afraid, like there is a risk, like there is a issue of overdoing, and that overdoing can bring a disrepute to the tools. Such incidents have occurred with the Kshara Sutra, Kshara and so on. So the important caution is, whenever you follow a tool, any technique of as such, know the limitations of that, and the exact indications they are to be used should not be used irrationally. Any tool in your hand should not be used freely everywhere. That's all the message there. That's about issue. Then comes the Sivana, wound closure. Of course, the basic principle of the wound closure is the same, like to achieve the primary healing, the wound is closed, and the technique of wound closure mentioned by Sushruta are exactly the same. The needles, they are exactly the same. Atraumatic needles are used. The technique of suturing, they are the same, like you have Virlitaka, Gofanika or Tunasevani, almost the same as such. Even the suturing materials, like the materials of plant origin, materials of animal origin, like snayu, bala, or even ant heads being used as substances which are absorbable sutures. So having that variety of absorbable, non-absorbable sutures having variety of curved, straight, cutting needles and so on. And the indications also are very specific, almost to the same detail which is used in the current surgical practice. The only difference, of course, is that in the current technique you have more options as far as the suturing material. You have many synthetic materials which are not available in Sushruta period. Otherwise, they are the same. You have some more development, but concepts of suturing almost remain the same. Virtually, there is no difference. Then comes the another area of the surgery in the major surgical indications, reconstructive surgery. Now, in the present day situation, reconstructive as plastic surgery, as well as plastic surgery, they are put into the same category. Plastic surgery is also having one more aspect, the cosmetic surgery. Sushruta would not do that cosmetic surgery, but reconstructive surgery is a basic idea of Sushruta. Where a organ has been damaged, either as a result of the disease or maybe due to the other injuries. In such conditions, trying to bring back the organ to the normal shape or normal functions also possibility. That's the idea of reconstructive surgery, and Sushruta had already established the whole concepts of the reconstructive surgery as Karna Bela Bandha, Nasa Bandha, or Vaikrapaha Chikitsa in the Vrana Chikitsa, where these are the basic concepts which are mentioned. And these details also are established as such as the standard protocols. Many of those principles of the plastic surgery are still adopted in the present day surgery. In the present day surgery, another major area which is added on is the cosmetic surgery, where the shape of the body is modified, which is not cup of tea by Sushruta. Sushruta had not tried that, and Sushruta would not consider that as an essential tool because surgery is the Jaghanya. Now, that's about the basic concepts of the surgery as in Sushruta as compared to the contemporary. I have picked up a few. We can go on that issue as infinitely. I think that's the limitation of the time, but I try to give you some examples of that. Then comes the issue of ethics and principles. As I told you, the three components of the surgery, the concepts, then ethics and principles, then comes the technology. Now, with the surgical ethics and principles, the contemporary surgery would consider autonomy, beneficence, non-malfeasance and justice as the basic ethics of surgery, and the principles are mainly the principles of diagnosis, principles of counseling and consent, principles of team spirit, and the choice of techniques like access, selection of right techniques, collateral injury, safety. I will come to these issues somewhat in detail. Then, of course, the wound management and healing, rehabilitation. Now, these are the basic, considered as the basic ethics and principles of the contemporary surgery, and the world over, these values, ethics and principles are recognized as the main benchmarks. Right? For every surgical center, the assessment of the surgical center is based upon these ethics and principles followed, and the benchmarks are there. So, whenever there is a issue of assessing a center and accrediting a center of surgery, these issues would come into the picture. Again, I will not go into the very detailed approach of that. Try to compare a few of the issues which are mentioned in Sushruta and what we follow. Now, among them, I will pick up only a few of those. I will not go into all of that. Again, it will be a very huge detail. Like one of the important issue in the surgical practice is informed consent. Now, you are legally bound to have the informed consent, and that whole evolution of concepts of the informed consent is started with the Nuremberg Code of 1949. The background is, again, I will not go into the background. If you do not follow the current rules or current law related to the surgical consent, informed consent, you may be affected by the law of tort, or a case of professional negligence, or law of contractual obligations, or criminal law of assault or battery. So, informed consent is one of the essential issues, and the informed consent would be having the major component is to give all the possible adverse effects of the surgery. Or if you have informed the patient about all the possible adverse effects of the surgery, and if such an event has occurred after the surgery, you are not liable for the these procedures like or judiciary review. Whereas if you have missed any one of the detail and the same has occurred after the surgery, then you will be punished as a surgeon. So that's one of the issues of concern, and which is essential legal issue. We cannot escape from that rule. Every surgeon has to follow that, and every practicing surgeon would be knowing about it. And the consent could be either implied or verbal or written consent, but written consent is given the maximum value, and every negative aspect, the basic issue is every possible negative issues of the surgery, including all the possible complications of the anesthesia, all the possible complications which can occur during the healing of the wound, possible complications which can occur during the rehabilitation phase, they have to be explained to the patient, and the patient has to give a consent. Now, from the point of view of psychology of a suffering patient who is not well versed with the legalities, you think about that, that negative feeling will make the patient nervous, and that nervous attitude would be again affecting the outcome of surgery. Though we know that we cannot escape that. Again, when I suggest about what Sushil has said and comparing that, I am not suggesting that you have to follow what Sushil has said, but till the current law is there, we have to follow the existing law. But my criticism is to the current law, and compared to what Sushila has done is, Sushila's method of consent would be ततः प्रशस्तेषु तिथिकरणमुहूर्तनक्षत्रेषु दध्यक्षत अन्नपानरत्नैः अग्निं विप्रान् विसर्जश्च अर्चयित्वा कृतबलिमङ्गलस्वस्तिवाचनं. The important part, before the surgery, the patient has to worship the gods, and the doctor will be blessing him, rather any seniors will be blessing him, and this positivity, that by approach of the positivity would be the basic issue of the consent given by or format, something like a consent. It's not really a translation for the consent, but something like a counseling of the patient prior to the surgery. A counseling of the patient, according to Sushruta, would be to give you the positive outlook and make the patient having a positive vibe at the time of surgery, whereas the current concept of consent would be giving a negative vibe. Though it is so, you cannot escape. Again, I repeat, we cannot follow what Sushila has said because the law doesn't permit you, because we are living in the society and we have to follow the current law. But theoretically, if at all you have to compare, naturally, I would always be that positive approach as something really valuable, and negative approach has to be has to be maybe somehow maybe modified if the law changes. So till the law changes, we cannot follow that. Now, it's not that the surgeon would be having a free hand. If the outcome is to be poor, in such a condition, surgeon had an obligation to inform the legal authorities. It's not that the negative issue is told to the patient directly, but the legal authorities of the patient, either it could be the king of that time or it could be the patient's caretakers, they have to be approached, or they have to be explained about the outcome, and then the surgery had to be done. This is exactly what Sushruta said. Akriyayam dhruva mrityuh kriyayam samshayo bhavet tasmad apritya kartavyam ishwaram sadhukarena. If the prognosis is poor, if the outcome is going to be poor, expected to be poor, then you have to inform the patient's caretakers or maybe the king administration, and then do the surgery. So that possibility of misusing the belief of the patient or the faith of the patient is negated in Sushruta. That safety precautions also are there. At the same, that positivity is there, and that idea of consent or maybe counseling, if consent is not the right word, counseling, somehow has to be now brought back. But till the legal permission is not there, we cannot do that. But we always can plead for some changes in that rule of consent, that laws related to the consent now. Anyway, that's one part. Then comes the beneficence as one of the basic ethics of surgery. Now, the whole method of, or the whole origin of urge for practicing surgery according to Sushruta would be तत्र सुखैषिणां रोग उपशमार्थम् आत्मनश्च प्राणयात्रार्थं प्रजाहितहेतोः आयुर्वेदं श्रोतुमिच्छामः इह उपदिश्यमानम्. When Sushruta approached Dhanvantari for teaching, the whole purpose of approaching the teacher to learn Ayurveda would be to facilitate or help the people who are suffering. And the suffering person is considered as a person who is suffering due to the disease is considered as Sanathanapi Anathavat Vichesamanana. A person who is suffering from the disease, having the pain, even if he has many caretakers, even if he is a healthy person, he has lots of resources, still he is as good as an orphan. No one else can share the pain. It's only the physician who can share the pain or maybe reduce the suffering and help such a situation. And the role of a physician at that moment is just to wish for the welfare of the patient, Sukheshana, Rogopashamartham. At the same time, it's also a means of living for the surgeon. So, in the professional ethics, the welfare of the patient is the first priority. Returns you get would be the next priority. It's not that you just neglect the returns. It's not natmartham, natikamartham, bhuktadayam prati. That's not the issue. You have to get something return, but return would be meaningful, and it should be only after having the comfort, providing the comfort to the patient, or giving the benefit to the patient. Then only the beneficence has to be done, and this is a very valuable principle of beneficence. At the same time, Sushruta also would be giving the guidance, like comparing the patient to a faith, or having that approach of the patient to the physician. That faith of a patient on the physician is described as Mataram Pitaram Putran Bandhavanapi Chatara Apyetan Abhishanketa Vaidye Vishwasametcha Visrajati Atmana Atmanam Nachainam Parishankate Tasmat Putrapadenam Palayed Aturam Vishakar. A relationship between the physician and the patient is compared to the relationship between a son and the father. And a person who is suffering from the disease may not believe completely any of his close relatives, like his mother, father, or so on. He may suspect them, but he will have a full confidence in the patient. And hence, it is a responsibility of a physician to reciprocate to that faith in the patient. And I think there cannot be any better description about the beneficence principle in the field of medicine. Though in the current medicine, we all know and everyone knows that the theory of beneficence is just put into the background. Most of the times the practice is not really followed. Then comes the issue of justice. Again, justice in the issue of justice in surgical practice is to know the limitations. Basically, when not to do, how not to do. If you look at the history of Western surgery, in 1995, there was a big conference in Mayo's clinic in the USA, and the whole purpose of that conference was to define an efficient surgeon. And the deliberations continued for 5 days. Surgeons from various disciplines from all over the world had to put together their mind, and the ultimate one sentence description of an efficient surgeon is efficient surgeon is the one who knows what not to do, when not to do, and how not to do. The efficiency, I repeat, efficient surgeon is defined as a person who knows what not to do, when not to do, how not to do. It's not what he does, it's not how he does, rather how he knows his limitations. Now, that's exactly the principle of justice in surgery. And when Sushruta says the sentence which I have told in the beginning, repeat the sentence, that the Upakrama Jaganyayam, that Jaganya Upakram, considering that limitations of the tool which you have, considering the discipline which you are following as Jaganya, as inferior, keeping that in the mind, like you have something uncertainty in the whole protocol, keeps you aware, and that you will be always knowing about what not to do and how not to do. And with that, you have to be selective about using the tools, like sadhyan sadhet, yapyan yapet, asadhyan naiva upakrameta. So, before you do the surgery or before you intervene, you should know the outcome and it should be judicious. If it is not in your limit, you have to refer the patient to an area where there will be better service available. In the current situation, this becomes quite more relevant because in the contemporary field of medicine, there are many situations where a better facility or better outcome can be achieved with the different tools, technology and so on, no dispute about it. and a patient should not suffer because of your allegiance to your system, like Ayurvedic, because you are an Ayurvedic physician, because of your commitment to Ayurveda, patient should not suffer. That's one of the basic issue, and this fact has become quite relevant when you go into what Sushruta says. Like then the principles of righteousness, like you should always have a area of zero error, and in field of surgery there is absolutely no scope for error, and any error should not go unpunished, and they or rather that you have to have something coming back to the error. That's what the basic issue of surgery. If you do an error, you have to suffer something like. Now, Sushruta has analyzed that scope of the error, possible errors, and method of achieving that error-free technique. Very beautiful, and virtually there cannot be any better description for that principle of righteousness than what Sushruta has said. See, errors in the practice can occur due to मिथ्यादृष्टाः विकाराः, दुराख्याताः तथैव च, तथा दुष्परिमृष्टाश्च मोहे चिकित्सकम्. If the physician is not able to make out or see the signs in the patient, if the physician has not taken proper history, and if the physician is not able to correlate that history and science which he has seen with the previous knowledge, if we cannot really perceive the condition, then he will be confused and he will not be able to make the decision correctly. And a person who doesn't make out the correct decision and who doesn't properly follow the techniques. Now in surgery, in addition to that making decision, you also have to have the technique, the hand and eye coordination, and that the whole activity of the surgery. One of the drawbacks of a surgeon would be he may injure himself, and such a surgeon who doesn't follow the proper technique. Sushruta warns the people, like you have to avoid such a surgeon, like vivarjetu ayuhu abhipsamanaha. If at all you have to survive, then you have to avoid such a kuvaidya, a surgeon who doesn't follow the right technique properly, you have to avoid. And to achieve that zero error target, the tools which are mentioned by Sushruta are Vaksaustave, Arthavijnane, Pragalbhye, Karmanepune, Tadabhyaseta Siddhau Chaiteta Adhyanantavagaha. The method of study should be methodical, it should be always step by step. The first step in studying is Vaksaustava, having that clarity of what you have read and may be able to express that. Arthavijnana, a understanding of the meaning of what you have studied. Then Pragalbhye, a skill to adopt that meaning into the current situation. Then Karmanepune, a skill of handling, the skill of practice. Then it's not enough if you have a skill of practice on one or two patients, it has to be repeated done, and only after repeated done, then only it can be, you can receive the siddhi or perfection. But all these protocols has to be through a proper method. Shastram gurumukhodginam adayata upayasya asakrit. So te vaidya anyetu taskaraha. You have to follow or you have to gain that technique or tools through a gurumukha, through a methodical training by a teacher. Then only it can be achieved, otherwise not. Now this kind of a principle is the most important issue of reaching that level of righteousness where you will not make any wrong decisions in the surgery. Then selecting the right choice and technique is one of the issues. There is always a multiple options. For any treatment of asset, you will have many options, and to make use of that decision, like which of the tools would be, which of the single or combination of the tools would be useful, that requires a lot of experience, and that's exactly what Sushruta says. You make use of any number of techniques to achieve the target, depending upon the clinical experience or experience of the others, or as per the documented protocol as such. Then principles of the team preparedness. Surgery is can never be achieved by a single person. Surgeon is only the captain of the team. The team is quite important, and Sushruta always would be spelling out and defining that necessity of the having a team as one of the basic necessity for reaching or starting the practice. In the Vishika Anupravesha is starting the medical practice. Susahaya Vata, having that team which gives you the support, is given maximum stress over there, and of course all the other basic issues, basic concepts or basic etiquettes of the practice are described. Among that basic etiquettes, one of the most important issue is Susahayavata, the team which is capable of dealing with the activity of the practice as such. Then principles of the diagnosis. Now principles of the diagnosis, in the present day situation you have a lot of issues like evidence based practice, and the evidence based practice is considered as the standard now, and you have lots of issues as such. Sushruta has established almost the same issue, but not at the same level of what we call as the evidence based. Instead, the gaining of making the diagnosis would be a basic concern of a physician. It starts with even before you see the patient. If you hear about a patient, your involvement with that patient should be there, and that's exactly what Sushruta says as Dutanimita Shakuna Mangala Anuvamyana Atragraham Abhigamya. The moment you get a report or maybe a news that a certain person is suffering, before you start examining, that whole process of making the diagnosis should start in you, and then it has to be evolved step by step by taking the history, then examining the patient, and then all that your previous knowledge it has to come in. Now, in the present day situation, you have lots of tools to make the diagnosis, laboratory investigations, imaging tools, and so on. Now, Sushruta, you make use of a very basic, very standard tool to confirm whether the patient is abnormal, whether the signs you have elicited in a patient is normal or abnormal, would be by comparing what the normal person would have by Atma Sadrishesha Vijnana Abhipayesha Tasthaniyehi Janiyata. Whatever you have observed in that patient is normal or not, is by comparing the same sign or same feature in the examining physician and see the difference. In the present day situation, this issue of comparing that normal values or establishing the normal values is based upon the statistics where a huge data of a huge number of people is collected together, and then you have that standard data charts. But these standard data charts have limitations. Most of the data charts which you have, which are considered as normal biological values, they are presented in the Western country and they are built up. That data is built up in the Western country. Unfortunately, in India, we do not still have that kind of a system where such data charts are developed and the normal values are established for India. But the normal value in India would be totally different from the Western countries because the differences are huge. Genetic differences, environmental differences, dietary deficiency differences would be there, and hence there would be always some differences there, and these differences would be making a huge difference in the approach to disease. Many times, comparing to the values which are seen in the Western countries, which are considered as standards, normal standards in the Western countries, and if you compare the same in India, you will be making many healthy persons as diseased, and so on. And there are the other lots of I will not go into those controversial issues about the normal value, but there are lots of controversies, lots of issues related to the economics of practice as such, like the normal blood pressure. The normal range is changing. In 80s, the normal range was considered as 150 by 80. Now it has come to 120 by 60. By this, the total turnover of pharmaceutical companies which produce the medicines has been changed, and these are all the issues of controversy. But instead of going for such a issue of statistical inferences, Sushruta makes us a tool like making use of your own as a normal and comparing it to the normal. Or similarly, making use of a biometric tool for administration of the drug, or like what we call as the prakunchamanam or prasrutamanam, the assessment or measurement of the quantity based upon the size of the fist of the person, either open hand or the other way. These are all the basic issues which are very unique of Ayurveda, and we have lost that. Then the surgeon's traits, the qualities of a surgeon, as per the standard protocols of the current day situation, as per the education resources org, the surgeon's traits are intelligence, professionalism, consciousness, creativity, courage, perseverance on behalf of your patient. Whereas Sushruta has said exactly the same: Shauryam, Ashukriya, Shastravekshanam, Asvedave Putuhu, Asammoshcha Vidyasya, Shastrakarman Shakshite. And the patient's commitment on the patient, something which I have repeated earlier, having a commitment to the patient as a surgeon's trait asset, compared to what we see in the current situation, this commitment to the patient is not mentioned as a surgeon's trait, whereas Sushruta has mentioned this as one of the major traits, as there it stands out. Now, with all this, may you see lots of issues which are rather more standardized or maybe more advanced in Sushruta, or maybe still there are values which are still related to. But the principles of whatever Sushruta has mentioned and what we call as ayurvedic surgery is in a very critical situation now, and I am not going to that part. So naturally the question comes in, why and how the gap is there. I would be considering this gap, or all that new development or the advancement of the current surgery is based upon major two issues: the technology, development of the technology, and data pooling and review. The most important aspect in which Western surgery or Western medicine rather as a whole has developed is based upon the technique of data pooling. There is about the case, patients and outcome. They are pooled together. You have many such tools where the data are pooled together. They are analyzed and reviewed, and the guidelines are drawn in. And these guidelines have really added to the development of the medicine, and at the same time newer technology there. Compared to that, we have lost, Ayurvedic stream has lost the pace because of that absence of the data pooling and review observation. And somehow the current these policy makers, they have started the website like Dhara Online and Ayush Portal, where an attempt to do the data pooling is done, very appreciable effort, but still whatever is done is not yet enough. A lot has to be done, and there is a lot responsibility on all of us, the generation of Ayurvedic practitioners, to support this effort of pooling, data pooling, make it more streamlined, so that there would be an inherent mode of development and the pace of development we pick up, and that would be the issue. Then comes the technology. Technology, of course, is one of the basic tool or basic factor where the current surgery and current medicine has developed, whereas Sushruta would consider the man behind the technology as more important than the technology. See, technology has gone to that level now where it has overtaken the human values, maybe, possibly. That's one of the criticism. But basic idea of Sushruta would be technology would be used. Surgery, the whole Shalya Tantra is a technology. Making use of Yantra Shastra itself is a technology of Sushruta. But at the same time, all that technology would be considered as under the control of the human being. And that's why Hastameva Pradhantamam Intranam Avgacha. Tadadinatva Chandra Karmanam. The Yandra Karma, all that technology would be under the control of the human being, and that human values of the technology has to be used. Whereas in the current development as medical science, we are coming to a level where the criticism is on that part, like the technology has overtaken and has reduced the human values. And the limitations of the technology, it's not only me who is saying. Persons like Albert Einstein a few years back has specifically mentioned that the day that technology will surpass our human interaction, the world will have a generation of idiots. This sentence is becoming a reality, and that's at that situation where we have a scope. Ayurvedic doctors should have a scope. And what I would say, this is the point where we need to preserve our identity. And one of the basic issue with the practitioners of Ayurvedic surgeons now is the issue of identity crisis. You know that there is already many litigations, many issues in the court, like whether Ayurvedic surgeons can do the surgery or not. Though you have the gazette notification of 56 surgeries and so on, I will not go into that part, but it's quite obvious and it's understood that the issue of identity crisis. Now, I will not go into that controversial issues of why and how and who is responsible. I will be putting it the other way, like how we can maintain our identity. What can be done? Now, to do that, to have that some niche for the identity, I will go into the issues like the surgical solutions. Now, almost every disease, it has come to a level where surgery is done for almost in every system of the body, and the scope of surgery, indications for the surgery has become increased too much now, and surgery is really overpassing the system of medicine or other systems in the present situation because of the technology, tools, safety, and so on. I will not go into to that part. So surgical solutions have become a major issue. It has led to that level where one of the basic issue now in the basic debating issue in the contemporary modern science, medical science, is to go for a surgical conservation. Now surgeons have done a lot of things. Surgery has become very popular, and now you have a very strong ideology coming up, like many of these surgeries done are unnecessary. So unnecessary operations done are now one of the basic issues or basic issue of concern of the health authorities. And in the Western system, the voice is coming up, and a lot of fight between interventional and non-interventional scheme of the treatment is coming up there, and it's one of the major debating issues. I have picked up a few of the sentences from some of those publications. 2.4 million unnecessary operations are performed on Americans at a cost of $3.9 billion, and 11,900 patients had died from unneeded operations. Reference is there. Or the surgery, another of the references, I am just picking up a few sentences from some of those important peer-reviewed publications. It's not my sentences, so don't say that I am criticizing it. The issue just to highlight, to see that they show that the issue is being concerned. Like, we perform surgery because we have been trained to do so, and because we have always done it this way, or we simply do not know any better. So in German psychology, this behavior is analogous to historic entity called Frankenstein lost. Now the idea of the respect to the surgeon, or the whole approach to the surgery has come to that level. It's a functions lost as such. And it's not only few of them, now lots of publications are coming up. Those who are interested, they may go through these publications, references, peer-reviewed articles, where the issue of unnecessary surgery is discussed in detail, and the gravity of that issue is discussed in detail from the current point of view. It's not only in the field of medical publications, it has come to the level of the general news also, news media also. In one of the news media publications in India, where 44% of the surgeries are unnecessary. It says second opinion givers. Times of India publication, dates are there. So the criticism on unnecessary surgery is one of the issues. And from our point of view, I think from Ayurvedic point of view, we should keep that value of Sushruta, that consultative approach. Avoiding the surgery would be one of the major identity of Ayurvedic surgery. Now, I just give you an example of what my practice is. In my practice, when I started my practice in 1983, of course, initially I couldn't maintain the data properly. From 1889 onwards, I have maintained the data. Hemorrhoids management in my practice, just give a few examples, is in the first span of 5 years, 1989 to 2004, the total number of hemorrhoid patients which I have seen are so much, and out of them, majority was treated by surgery, because at that time younger surgeons would always have a idea like intervention, hemorrhoidectomy was done. Medical management was limited to only a few of the patients. Kshatrakarma was limited to a few of the patients. Now compared to that, in the last 5 years, 2014 2019, of course the next 5 years data, 2014 to 2019 to 23 data also are there, it still has a better issue. The number of surgeries done, hemorrhoidectomy is lesser, number of patients seen are more. So is the case with the appendicitis. In the appendicitis, I am just giving a few examples of what my practice has done. In the beginning of my practice, 83 to 2004, number of appendicectomies were more, number of medical management were lesser. In the present day situation, the number of medical management, non-surgical approach is more, and the surgeries are becoming lesser. Now, all this is possible because of a ayurvedic protocol of the treatment, and avoiding the surgery has become an identity. And it's a very interesting issue. Number of patients I get are more because there is a social image that this person will not do surgery unnecessarily, and the people who want to avoid surgery, they are preferring to coming to me. So the issue is it's a very sensitive issue. When you start practicing surgery, you will always have a feeling that more you do, you will become more popular. And it's the same story with me also. I too, when I'm not saying that I'm beyond that. It's quite true that in younger age you will have that kind of feeling. But later, the other way, your identity can be modified, identity can be preserved as a conservative, and the society recognizes it. That's all the important issue. Society recognizes it, society values it, and society needs it. Similarly, non-surgical management of surgical conditions can be achieved in a huge area like IVDP, cholecystitis, renal calculi, prostatic hypertrophy, IHDs, diabetic foot, varicose veins, peripheral ischemic disorders, and so on. With that, the identity can be maintained, and that identity would be very valuable, and it can reduce many of the controversial issues which we have. That competitiveness in the current situation, the modern medical associations like IMA, they are having a open sword criticizing Ayurvedic surgeons and so on. Many of those issues can be resolved safely if we maintain an identity of conservative surgery. So one of the basic issues I would recommend for an Ayurvedic surgeon's identity would be conservative approach. Another, of course, is combining the medical tools with the surgical tools and having an approach to a management where you will have a better results. Now, again, I will not go into that detail like how and disease-wise approach. I will try to give you one example of one of the patient's issue. Now, a very interesting issue with this patient. This patient is a young boy who met with a road accident, and he had a very complex fracture of the ankle, at the ankle. He went to a renowned modern hospital, and in the modern hospital, he was recommended for a amputation. First stage amputation at the ankle was done, but somehow the patient didn't require. There was the review. There was a need for review, and the patient was re-amputated at below knee amputation. A below knee amputation was done, and even after the below knee amputation, there was a evidence of the femoral artery being blocked, and that amputation stump had given away. And by the time, naturally, the patient was a lower middle class family, and he was in a very sophisticated hospital. Naturally, the patient would always have a notion like this, they cannot continue with that. Patient was recommended for a third revision of surgery. The amputated stump has given away, and at that time, somehow the patient's party felt that they cannot manage with that hospital. They preferred Ayurvedic hospital. At that time, there is a general notion in the society. I would always say like, जिसका कोई नहीं है यारो, उसका तो SDM है यारो. SDM hospital, our hospital was is having that reputation of having the last resources, being the last resource for all those where they do not have any hope. So at that kind of a critical, hopeless situation, the patient party opted for an Ayurvedic treatment, and he preferred to come to Ayurvedic hospital. The hospital which was treating that, I am not naming the name, the hospital which was treating that patient discharged him against medical advice after having an indemnity bond. And when the patient's party said that they are going to Ayurvedic hospital, there was another double indemnity bond. The patient was brainwashed that if you go to Ayurvedic hospital, you will die. But somehow the patient's party had a faith, and they came to us to the hospital on 27/12/2017. At that moment, the stump had shown lots of necrosis tissue, and the whole stump was unhealthy, and this is the image of that. Now, that patient was given a Manjustadi Ksharabasti, and of course a course of old generation antibiotics, gentamicin and metrogyl was given. And interestingly, the vascularity developed, some became vascular, the Manjustadi Ksharabasti. Day by day, the progress was there. 27th, this image on 27th, 28th, you could see some changes. 29th, a better vascularity. 30th, again, the whole stump has become that visibly vascular. The stump had that a better appearance, and I did the resuturing of the stump on 1st January 1st in 2018. So after 1 week of Basti, the resuturing was done, and the stump has healed well, and the patient now is able to walk. And now, of course, there is a process of the patient is able to walk. That photograph is not there. My purpose of showing this or reporting this case is to show, like, see, by combining that principles of Ayurvedic treatment of Manjustadi Ksharabasti, a critical situation where the patient had to undergo a third revision of an amputation, which would be quite painful and quite sensitive also. You can imagine about the psychological status of a patient, young patient who had to undergo a third amputation in a span of a month, and the financial burden also. So that can be avoided if you can combine the principles of Ayurveda with the current technological tools, current surgical tools. Instead of going to a high technology tool, with the same basic principles, we can achieve such a result where the contemporary system may be at a blind end. And that negativism in the society, like a hospital making a patient to give a double indemnity bond or something high level indemnity bond when he says that he goes for an Ayurvedic treatment. All that kind of issue, bitterness and the harm to the patient, or a patient's choice of coming to an Ayurvedic treatment as a last resort. Instead of making that, why, if at all there could have been a situation where both these streams would have put together, advantages of the Ayurvedic stream, the Ayurvedic principles were adopted in the beginning itself, and the patient's suffering could have been reduced. It could have been a utopia, it could have been a wonderful issue. And from our Ayurvedic surgeon's identity point of view, we should seek for such situations where combination of our traditional core value of surgery, the core principles of surgery, with maybe the contemporary advances to produce the better results, then our identity can be maintained. With this, let me conclude. I think I have taken the time beyond the limits. Sorry for that. The concluding my carry home points are: Ayurveda is a perfect blend of medicine and surgery. Sushruta is the treasure house of surgical excellence. Techniques described 5,000 years ago still are relevant even now, and many times they are the real guidelines for the future. Emerging technology can be adopted. Science identity crisis. One of the troublesome issue now is many of our Ayurvedic stream surgeons, they are after the technology, and if you go after the technology is going on such a pace that you cannot cope up with, and many times there is a possibility of we lose our identity, and that identity crisis has resulted in many of those fights for crumbs, like the litigation and so on. So I think we would not do that. We would like to maintain an identity of our own, basing that keeping our basic values, and it's an absolutely needed that the eventual interest of welfare of the humanity needs preservation of legacy of Sushruta. And of course, instead of keeping the identity as a separate issue, it could have been better if a national system of medicine synthesizing the advances of present with the ideology of the past would have developed. But question remains, like, will it remain to be an utopia or will it be reality? With this, let me conclude. Thank you. I hope there could be some questions, and I would expect feedback to these mail ID. If there are any questions, I will try to answer. Then again, thank you for patient hearing. I think there are something like voice is not clear.
Thank you, sir. Thank you, sir, for this very interesting and very informative session. Sir, your expertise and knowledge on today's topic is truly valuable and your lecture has provided us with a deeper understanding of the topic, sir. And on behalf of all the participants and the entire organizing team, I express our sincere gratitude and thankfulness to you, sir. Now it's the time for discussion, and I look forward to rest of the session under Dr. Sridhar sir's guidance. Once again, thank you, Dr. Sridhar sir, for giving me this opportunity. Over to you, sir.
Okay.
Uh, Thank you, Anuraj. Thank you, sir, Muralidhar Sharma sir, for such an really step-by-step and relatively explaining the oldest concept of surgery, which has been very nicely put forward and heightened. That fits to this today's context, and that would be really a very what we call impressive as well as most inspirational talk for the youngsters to come. So, is there any queries? Anybody can unmute themselves and ask the question to the speaker. I don't find any.
They may take the question in the chat box also.
Yes, it is not there, sir.
Okay, fine.
There are certain. I mean, there was an issue in the slideshow related to that. There was.
I could go through that.
Yeah. Anybody?
If there are no questions.
Yes, sir. Yes, sir.
Yes, ma'am.
Yes,
Please
sir. I
unmute
have a
yours.
question. Namaste, sir. Yes,
Yes, please.
sir. Yes, sir. Yes, sir. We say that the surgeries have been explained in our samhitas, and also we should be allowed to perform surgeries. And at the same time, allopathy surgeons ask us then show me where it is written that how to perform appendicectomy or herniectomy or cholecystectomy. Then what should be our answer, sir? Like they ask very technical questions.
See, that's simply going into the detail. It's an issue of going into the detail. Technology is not a property of anyone. See, modern surgeons cannot claim that technology is bare truth. Technology is developed by different streams of the physicists or maybe biochemists and so on. So, nobody can claim that any technology is their property. And doing that, whatever the technique we follow, it's not necessary that it should be described word to word in detail, but principles are mentioned in the samhitas. Like as you said about the surgical treatment in case of hernia, of course, Andhravruddhi Sushil has mentioned about the surgical treatment. The techniques are different, of course. Techniques are not to the detail. The difference comes in only in the detail there. So if you follow the current available detail, that's fine. There is nothing to criticize about it. Then comes the issue of post-operative management, where you have to make use of the tools. There again, there is no controversial issue now. Of course, the policy makers are supporting us. Now, all that question comes in only when there is a feeling like there is a competition. If you are presenting yourself as a competitor to the other surgeon, and when it comes to question of bread and butter issues, naturally they would try to claim and then try to push you to the background. In such a situation, if you maintain an identity of your own, which is totally different from that, the society will recognize you. Like as I told you, see, when we do the surgery in our center, people come to us because they feel that the surgery would be done only when it is necessary. It will not be unnecessary. That conservative idea, that itself is one of the major value in our center, where the patient come with that feeling as such. They try to avoid surgery. They come for a second opinion, even though they have an appointment of surgery elsewhere. Then the other issue is develop a ayurvedic protocol of post-operative management, and that makes a difference. The society recognizes a difference. Now, so whenever we have such a issue, if we show that difference between your approach and the other approach, then all that criticism will be having a lesser resonance or lesser value as such. So that's the point. That's exactly the point which I mentioned, like we need to maintain our identity, and that identity will be recognized by the society. And that reduces the scope of criticism, and that reduces all that issue of righteousness and so on. As far as the using of the technology, basic technologies, nobody can claim that technology is their property. But at the same time, you should be proficient with the tool. The technology has to be handled safely. All the protocols of the technology have to be followed exactly as it is, and the safety precautions should never be bypassed. Technology is a tool when you use it safely with all the protocols, otherwise it can be harmless. It is something like a sword or maybe a knife you use in the kitchen. It can be used for the benefit or it can be used for the harm even. And if you are not skilled in handling it, you can harm others. So that part is the most important thing. So when you go for a surgery as an Ayurvedic practitioner, the first and most important priority is you have to have a perfect grip on the technology. Then comes the issue of identity. I think you are satisfied with the answer.
Yes, sir. Thank you, sir.
Okay, fine.
Someone has raised his hand and put a question in chat box that is there any role for Ayurvedic surgery in malignant diseases? Ahmad, you can unmute yourself and ask the question directly.
Mention the role of Ayurvedic.
Good evening, sir.
Ayurvedic surgery.
Good evening, sir.
I think there is absolutely nothing wrong in it. We can do that. But at the same time, when we go into all that protocol, one of the basic issues, that issue of giving the beneficence, like the patient's interest has to be preserved. So if you can provide a service which is equivalent or which is no way inferior to the service provided in the other center, definitely you can do. Nobody can prevent you from doing oncological surgery. But if you feel that there is a better option or better tool available to the patient in other system, your allegiance to the system should not harm the interest of the patient. So in such a situation, it's better to reserve it to those centers where those areas where a better tool is available. So that kind of a perception is quite important in the practice. It's a very sensitive issue of the medical practice. And it's not that by referring a patient to some other center, you will be losing the patient. By referring the patient to some other center, the patient's faith on you would be enhanced, and hence, and it also, it's quite important, like you should know the limitations of the contemporary surgery. I would always say that an Ayurvedic surgeon should be more modern than a modern surgeon. So limitations and the advantages of all the advantages of the contemporary surgery should be known well. Then only we can take a judicious decision and maybe decide like whether you can handle or whether somebody else can handle. That all depends upon the skill and facilities you have. Right? So there is no restriction in oncological practice. Definitely there is a scope, provided you have the skill, you have that ability to provide the service almost equivalent to whatever the other system gives in. Right? So,
Yes, sir. Thank you, sir.
Okay, any more?
Yes, sir. Sir, I have one
Please.
question, sir. Good evening, sir. Sir, my question is regarding the notification, gazette notification that the government of India passed, sir, in 2019 regarding the number of surgeries that we could do, sir, for Shalya and Chalakya.
Okay, fine.
So I would like to know what is the status of that, sir. Are we allowed to do the surgery, sir? And if so, if yes, then, sir, can we collaborate about that, sir?
I think when the gazette notification is there, it's quite obvious that there should be, you have that permission from the government to do the surgery. But of course, the issue is still sub judice. Still, there is a issue in the Supreme Court. In the Supreme Court, IMA has filed a petition against that notification. Issue is not resolved. So at present, it's under sub judice issue. So as long as the judgment comes from the Supreme Court this way or that way, the notification of the gazette is valid and you can follow. Then I don't know what would be the final judgment by the Supreme Court, I don't know. So future we cannot predict. So at present there would be no legal issues as far as your capability to do the surgery. But the other aspects are absolutely true, like the interest of the public and safety, all that issues are true. But as far as the basic legal issues, at present there is no inhibiting factor. And At the same time, the issue is still sub judice. Final decision has not yet come. So, if the Supreme Court, I don't know what can be the future. If the Supreme Court decides otherwise, the situations may change. So, at present, there is no issue. So, that gazette notification is valid till now. Okay.
So what about anesthesia, sir, and post-op management, sir? Because they will,
Yeah,
the modern
anesthesia,
people
of
say
course,
that.
yeah, see, facilities for anesthesia, you have to take the help of the others, or if you have the capability. See, course of anesthesia, again, issue of controversy. Banaras Hindu University had that course of anesthesia, department of anesthesia for quite a few years. Now, CCM has removed that post-graduation anesthesia. The issue is controversial, so I will not go into that controversial issue. But still, we can take the help of others, and the anesthetist would definitely help you. There is no inhibition there. So, if you have that maybe this cooperative environment, coordinated environment, that may not become an issue. You can get the help of anesthetists from the contemporary science as such. And of course, you can
And sir, sir, what about the post-op management, sir? Because modern people will give antibiotics, sir. They will say that it is necessary.
in our
Yes, sir.
center, we do treat the patients with the ayurvedic medicines like Triphalagol, Gangarsana, and large number of patients. But at the same time, I don't say that we never use the antibiotics. Antibiotics are necessary. They can be used to a certain extent. So again, because of the antibiotics or any contemporary medicines, we also is an issue of controversy. Some states have permitted, because it's a state subject, some states have permitted, some states have not permitted, some states are having restrictions, announcement of some restrictions about that. So that issue is there. But ultimately, the important is there has to be a social acceptance. If the society accepts it, if the large number of people in the society, they say that your service is needed, then all that law and the government would follow the society. In democracy, ultimately, the society is the final issue. So, whatever we do, it should be in the interest of the society. Then the society will safeguard your interest. So, instead of worrying about the legal issues, we need to keep that in mind, like the patient's interests are protected, patient is given the best service, and if the patients develop the faith and you have a community, a large number of patients behind you, that itself is a safety precaution against all those simple issues related to the legality and so on. I think that is the better answer than anything else. Okay, right. Any more questions?
Okay, sir. Thank you, sir.
Surya, from where you are?
Sir, I'm from Himachal, sir.
Himachal. Are you a student or a faculty?
Student, sir. I'm a first year PG student, sir, in Ramakrishna College, sir, in Bangalore, sir.
Okay, fine. For your information, with the permission of speaker, that here we in Hyderabad, Dr. B.R. Government Ayurvedic College, Department of PG Studies in Shalyatantra, I do surgeries, surface surgeries, anorectal surgeries, plastic surgeries to some extent without using antibiotics.
It's quite possible, sir.
So, yeah, so it is all that we need to work into the therapeutic aspect, not only making the surgical aspect. Surgery is only an art, is a skill of hand, but managing the case demands science, knowledge of science. So if you are thorough in utilizing medications and the concepts of Ayurveda, probably you will be able to do the surgery without using modern medications. And as far as my knowledge goes, the gadget doesn't permit you to do surgeries with all allopathic medications and all. It just says that you are allowed to do Ashtavida Shastra Karmas. You once go through the gadget properly, it says only that Ashtavida Shastra Karmas are permitted to perform by Ayurvedic surgeons. So there are a lot of issues, as our leader sir said. So it yet to be finalized by the Supreme Court. Thank you for that. Any more questions? Somebody raise hand. Please unmute yourself and ask the question.
Good evening, sir.
Yeah, please.
Sir, myself, Dr. Yogesh Kulkarni, sir. From VVS Medical College, Karnataka, sir. Sir, just I want to ask, sir, to Dr. Muralidhar Sharma, sir.
Yes,
Sir, at the Apex body, NCISM is implementing NTET programs for newly joining assistant professors. National
fine,
NTET, sir.
okay, fine,
A NEET entrance test for the for the aspirants for teaching professionals. Yes, sir. So, can we have the same like for a profession, for a surgical profession? Can we have such programs? Can we have training programs for
Okay,
after
why
MS?
not? Why not? Training programs can be done.
A mandatory, which can be mandatory.
Now, see, it's a very simple issue. Making anything mandatory doesn't resolve the complications, doesn't resolve the issues. Rather, making any issue mandatory would be making the issue mandatory would be rather many times will not serve the purpose. So it should be voluntary, but training, of course, can be done. So definitely, yes, there is no end to the training. Training has to be done, and the training is necessary. But making it as mandatory and bringing it to the that complexity of legal issues and maybe really spoiling the spirit of it. So once we make it mandatory, there will be always means of bypassing that. So I think I don't have any definite answer for that question. But of course, training is necessary and training can be done. Okay, fine, right.
Thank you, sir. Thank you, sir.
Yeah, any more questions, please? I don't find anyone to raise a question. But sir, I have a small question for you, sir. As we now we witnessed, and as we all being in the profession of Ayurveda, we to the extent possible, we know that Ayurveda has given very good basic structure of surgery, including everything, and certain even complicated surgical procedures, their methods, and so many other common basic needs and all, like suturing materials, sutures types, bandages, instruments, this and that, everything. It sounds as if they knew everything like. So, sir, do you suggest any guidelines for youngsters whereby they work towards trying to re-establish Ayurvedic surgery, dreaming that there is no other system existing in this universe? Like allopathy. We feel, first, I believe that we have a phobia that whatever allopathy system says is correct and whatever other system says probably not correct. And this made us not to work into our systems. So as a senior faculty from Shalya Tantra, can you give us any guidelines that if we work on these lines, probably we will be slowly understanding, we will be slowly able to get the confidence that we do surgery as the Sushruta used to do without fear of sepsis, post-operative sepsis and all.
I think certain of the facts which we have to accept are the time has changed. Now, in Sushruta's period, there was no competition. Sushruta was the ultimate. And probably if Sushruta would not help, Yama would be there. But the present situation is something different. You have a stream that has developed and which is giving service to the society in a different manner. Now, that's exactly the point which I would always say, like, whenever we treat a patient, that interest of the patient has to be preserved. I would always keep this in mind. Like, ultimately, we should be in a position to give the best to the patient. So, if we are sure that our techniques or our basic modalities of the treatment would give a better treatment than the contemporary, definitely yes, we can develop the same. If we are not sure about that, or if we know that the contemporary system would be giving a better tool or better outcome, definitely yes, the patient has to be guided to that. And even then, we will have large scope, vast scope to treat. See, there are many diseases, many disease conditions where the contemporary system doesn't give a satisfactory, accessible treatment to all. and that makes the patients come to an Ayurvedic physician for maybe any different disease, whether it is surgery or the other way. You have that. Or when the patient comes to a situation where he is hopeless, he may come to you. Now, at that kind of a situation, definitely yes, we have to make use of all the Ayurvedic tools which we have. The most important is we should have a faith in the system which we have, Ayurvedic system. We should have a faith, and at the same time we should know the limitations and the advantages of the contemporary system. Again, I repeat what I have told earlier. I have told the same, like if you have to be very efficient and meaningful Ayurvedic practitioner, you should be more modern than a modern doctor. You should be updated with the advances and the limitations of the contemporary system, and you should be in a position to give the best to the patient. So if you can do that, and if the society recognizes that you are providing the best to the patient, then definitely the society would accept. So we need to develop in such a way, our skills and our presentation has to be developed in such a way that we are in a position to give the best to the best of the stream from the society to the society. So with that idea only, I would always plead for a national system of medicine. See, this is a utopia now, where in a national system of medicine, we should have a established method where the best of the tool from the Western and best of the tool from the our traditional have to be put together, and we should be in a position to give this service to the society, not by choice or not by selection by the people, like by the rather untrained. Now see, today a patient, a common man, has a doubt like whether he has to approach an Ayurvedic treatment or whether he has to approach a modern hospital. And when you go to, when the patient goes to any system like Ayurvedic practitioner or a modern practitioner, naturally there is always a prejudice, like we always try to keep the patient within your hold. Now this is a very awkward situation which makes the patient confused, and ultimately at times it can harm the society. If at all we have a situation where we have a national system of medicine, where all these are put together, and we develop a protocol of treatment which would be standard and it will be available in every center, instead of having that contemporary modern system as a separate and Indian system as a separate, if we have a national system of medicine, that would be quite useful. Many Eastern countries like China or maybe many other countries have developed that kind of a facility, and that has given the results. And I hope the current administration is thinking of that issue, but lots of things have to be done to that. Probably that would be an answer to that question. I think I have given the perspective correctly. Is it right?
Yeah, yes, sir. That's all very fine, sir. What I was trying to ask is that it's all we will be doing, as you said, trying to do, probably in future also we'll be doing that. People like Raghram Bhatt sir and all will be making efforts for that, where we all other people will be cooperating with them and all. Probably we will be achieving that point. What I was asking you is that I'm not asking that as it is we should put whatever the Sushruta has given the information should be practiced as it is, but with the concepts and the primarily as someone has asked, that post-operative management. So in this aspect, what are the guidelines so that if we follow, probably we'll be able to understand the science in a proper manner. We will be having confidence and all.
Okay. Guidelines.
That's my question.
Yeah, the guidelines I think I would be giving only two. One is Ayurveda Upadesheshu Vidhe Paramadaraha. So you have to have that allegiance and faith in the system. The other is the interest of the patient. I think these are the two guidelines. We should preserve or protect the interest of the patient. And I would always keep that interest of the patient as the first, and the Upadesheshu Paramadaraha as the second. So any approach, any sort of new treatment, we will have to consider that. Then the other issue, like whether the protocols have to be followed exactly mentioned in the the text are changed. So I will give a different sort of example. See, our great grandfathers, they had visited Kashi for the pilgrimage. Now you are, from our generation also may visit the same pilgrimage center, that the core idea would be the same pilgrimage and then all that sanctity about it. In those days, our grandmothers, they might have walked, they might have used a bullock cart to achieve that. Now you may use a train, a flight, or so on, a tool which is totally different. But the core is the same. Core idea is the same. Pilgrimage, the theme of pilgrimage is the same, that sanctity and whatever that religions as such. So, in the same way, we can achieve whatever the goal or the basic principle of our old tradition, which is mentioned in the text. At the same time, we can make use of the contemporary available tools which are more advanced, which can save the time, which can make it more efficient, more specific, target oriented. We can make use of the tool. But when we make use of the tool, we should not lose our identity. So you have to keep these issues in mind, and then definitely yes, all that, all those principles that are mentioned in the text can be practiced, put into the practice if you keep these boundaries. I think probably with that we can develop. It takes time. It
Yes, sir.
needs a lot of effort, and it needs a lot of experience. That's true.
Yes, sir. Thank you so much, sir. Thank you so much for your clarity. Anyone else want to interact? Yeah, I don't find any queries, but I find so many some very good renowned personalities joined in our webinar, sir. We have with us Dr. Jayashree Natarajan, madam. Madam, good evening. Hello, Jayashree, madam. We are also having with us Dr. Salimat sir, who is a principal from Bagalkot Ayurvedic College. Salimat sir. Yeah. Dr. Vijayalakshmi madam, we had been. Dr. Vijayalakshmi madam.
Sridhar.
Yeah, we have with us our former additional director and principal, Dr. B.R.K. Government Ayurvedic College. Madam, can you please express your words about this?
Sridhar, I joined after some time later, but after that I followed the lectures and question answers also. Answers were good, very nice. So I can comment this much only today.
Thank you. Okay. Thank you so much. Hope that everybody enjoyed the today's session. Sir, Raghuram Bhatt sir, I think he has left. So we close the session by a vote of thanks. We really, sir, thankful to you, Muralidhar Sharma sir, for your very insightful information. Usually we know that we hear from scholarly persons that how